So, good afternoon, good evening, and once again I'm here with a panel. So, we had three important lectures in previous few minutes. One about prostate, one about kidney, and one about bladder cancer. And we gained good knowledge about these cancers in last few minutes. So, we will be discussing about how we can put this knowledge in the real perspective in our practice in our clinic. I believe Dr. Hemang Bakshi is there because I don't see any uro-oncologist in this panel. So if Dr. Bakshi is there, I will be passing on a couple of questions to him during the panel discussion. I heard that Dr. Tejinder, Dr. Rajiv, and Dr. Satish are not there. So I will be asking the question to the other four panelists, Dr. Minish, Dr. Rakesh, Dr. Sandeep, and Dr. Indra. I hope these four panelists are there. So we will be discussing about urothelial cancers, renal cancer, and prostate cancers. So let us start discussing about the urothelial cancers. If I can ask the first question to a medical oncologist about what is optimum TURBT or maximum TURBT. What's our impression? And then I will pass on this question to the urologist. Yes, Sandeep, please go ahead.
Sir, good afternoon, Dr. Jasuja this side. So, in
Yeah,
our
yeah.
perspective, we want only to see the what is the maximum tumor size we can extract from the TURBT, because if we can see the lesion, muscle invasion, and non-muscle invasion, we want that also purpose for the further planning, and also the if we can define the extent and tumors lesion. I mean tumor. Margins, and that for TURBT, and later on for and that two are the main motive we want to discuss, and also any synchronous lesion if any can find on TURBT, then we have to extract that.
So,
Yeah, regarding
yeah, please go ahead.
optimum TURBT and maximum TURBT. So an optimum TURBT by definition is a TURBT well done. So it involves complete resection of the whole tumor as far as possible, number one. Secondly, it has to involve separately sent specimen of the deeper muscle tissue, including the detrusor. And maximal TURBT usually refers to a patient when we are going ahead with trimodality therapy or bladder sparing approaches, where you try and get out as much bladder tumor tissue as possible. So these terms are interchangeable. I mean, it's a matter of semantics mainly. But the primary goal of TURBT is to eradicate the tumor completely. One. Secondly, to have deep muscle in, for staging purposes, and three, to avoid complications like perforation, bleeding, clot retention, etc. So it's a very important procedure, not just for staging, but also as a part of therapeutic benefit for most patients.
So, Dr. Minish, will it matter whether the Nmibc non-muscle invading bladder cancer, whether it is low grade or high grade in the management that you are offering to these patients?
Yeah, obviously, if it is a low grade non-muscle invasive, it's going to be just a TURBT, and if it is a recurrent or a high grade, you may have to use something intravesical into those kind of patients. So it does matter what kind of histology you're looking at.
So does it mean that for a low-grade NMIBC, you will not be offering any intravesical therapy?
You can avoid it. You can, if it is a low grade, you're done at TURBT, you can repeat a scopy after a month and see. And you need not put everybody on an intravesical therapy. It's not compulsory. You may give BCG. Some people do it, some don't do it. Some want to give intravesical mitomycin, some are using gemcitabine. So there are various schools of thought. I believe that BCG is quite a good thing, but we should not jump onto intravesical therapies. They do have their own complications. You can always, anyway, the tumors are so low grade, they're going to take very long time. You're going to repeat your scopies. So you don't have to do it for everybody.
Chirag, if I can.
Dr. Rakesh, no, I will come back to you. Dr. Hemang, I will come back to you. Dr. Rakesh, if it was a high-grade NMIBC, will your approach differ and how?
So being a high grade makes it a for recurrence for NMBC. These are the criteria for recurrences: size criteria, grade criteria, recurrences, basically second or third recurrences. These are the indications for, I think, the local BCG therapy. And between MIBC low grade, between MIBC high grade, it's purely a call of stratifying them based upon the risk of recurrences. I think every high grade is a high risk for recurrence, so definitely they go for either BCG or mitomycin. Low grade size criteria, again, that would dictate whether these patients will go for BCG therapy or not. And as a medical oncologist, I rarely
So,
get to make a decision making for these patients.
Rakesh, will you suggest cystectomy to a patient with high grade NMIBC? Surgery, cystectomy for NMIBC high grade?
Whether the patient had a previous history of any renal pelvic involvement, or he had history of any nephrectomy done previously, or this is the first time he had a high grade NMIBC. These are the criteria I would probably look into it. Probably first attempt, if somebody had a maximal or optimal TURBT that shows a high grade disease, probably a local BCG treatment is sufficient. Maybe it's a recurrence, then definitely go for cystectomy.
Okay, and Dr. Indranil, what about the other histology of urothelial carcinoma? Will the
Yeah,
approach change or it is the same?
yeah, before I go into the other histologies, I think for high grade and PT1, we should strongly discuss about a repeat TURBT, because we can miss residual tumor and muscle invasive tumor in this group of patients. And yes, multifocal high grade, and if recurrent, I think radical cystectomy should be offered in this group of patients.
That's why I had written second TURBT down the line. But yeah, so that's a good point. And what about the other histologies?
Yeah, see, other histologies are quite rare. And most of the time we have to look into a lot of literature and all, finding what to do. Like if say urachal adenocarcinoma, sometimes we get. So treatment for these things are different. And sometimes partial cystectomy or even radical cystectomy can be there. And sometimes this small cell carcinoma, if it's there, then it's very aggressive. That management is totally different, like chemotherapy, radical surgery, all this.
Dr. Bakshi, your comments?
Yes, so a couple of comments. Number one, intravesical perioperative installation of a single shot of mitomycin is the standard of care. So there is level 1 evidence to show that regardless of the grade, which subsequently will come in the histology, any superficial or non-muscle invasive bladder tumor which you resect within 6 hours, if there is no perforation, no bleeding, mitomycin C single shot should be given. That is standard practice. That is number one. Secondly, you asked about the indications for Nmibc cystectomy. They are pretty standard. Number one is the CIS, so carcinoma in situ, multicentric non-muscle invasive bladder tumors, presence of hydronephrosis, more than 3 centimeters bulky tumors, involvement of prostatic urethra. All these would make me go for cystectomy rather than intravesical therapies. So,
and about second TURBT?
Sorry?
Second TURBT?
So when there is, the histology says that it is T1, lamina propria invasion, muscle tissue is present but not involved, then ideally you should go for a restaging TUR biopsy from the same scar. The reason is that about 20 to 40% will show some still viable tumor which will affect your subsequent decision making regarding conservative versus cystectomy. So I would recommend restaging TURBT to all patients who have had T1 high-grade disease, regardless of whether the muscle is involved, muscle is present or not. Muscle is not present, obviously you would go ahead and do a restaging TURBT. But even if muscle is present and not involved, it is still recommended procedure after the first TUR.
So Dr. Bakshi, what imaging you will perform before or after TURBT? For Nmibc?
Yeah, so standard would be a cross-sectional CT, contrast enhanced CT of the abdomen and pelvis. If it's suppose that Nmibc, it's a 2 centimeter tumor, no hydronephrosis on ultrasound, single episode of hematuria, I would go for a cross-sectional CT of the abdomen and pelvis before doing a TURBT. CT should be good enough.
Right. And how to follow this patient up? If it is Nmibc, how will you follow them up?
Yeah, so it will depend on the risk stratification based on the EAU or NCCN guidelines. So low risk patients would typically require less intense follow-up, like TALG, mucosal involvement only with low grade. I would do a cystoscopy at 6 months and then follow it up annually with a cystoscopy. If on the other spectrum, we have a T1 high grade disease, which has high risk or very high risk, then I would follow up with a 3-monthly cystoscopy and cytology and an annual CT scan. And this is for the first 2 years, and then every 6 months for the next 2 years, and then annually.
So, Dr. Bakshi, if you know that it's MIBC on the TURBT, will you ever go for the second TURBT?
No.
Before planning the definitive treatment?
Not at all. It is not needed, because once you confirm that the smooth muscle, the detrusor muscle, is involved by the malignant tumor, you don't need a second TURBT. That specimen, that is good enough. At the most, you might have a review of slides for a second opinion, considering the validity of the first report that this is indeed a muscle invasive tumor. But otherwise, it's not.
Dr. Minish, once you know that it's MIBC, what imaging you will prefer to this patient and when after TURBT?
Generally, we wait for at least 3 to 4 weeks before we evaluate patient. Generally, 3 weeks I would wait to get a PET scan done to see if there is a metastatic disease, nodal involvement, or any of these things. If we find that there is no involvement, if it is a loco-regional disease, then we will think of doing some kind of, either it goes back to the surgeon to go for a surgical kind of evaluation. If it is a loco-regional advanced malignancy, nodal involvement, or metastatic disease, in that situation, we consider them for chemotherapy. So PET scan. And if we are looking at operability of a tumor, sometimes we may have to do an MR also of that area if it is not adequately evaluated by PET scan.
Dr. Rakesh, PET CT scan is negative for metastasis, and CT scan or MRI, whatever, of the pelvis is showing that it is intravesical disease only. There is no extravesical extension. There are no nodes on imaging, but it is a muscle invasive bladder cancer. So, will you give neoadjuvant chemotherapy to all patients?
I would preferably give neoadjuvant chemotherapy for all cisplatin eligible patients, sir. This is what I would suggest to my patients and also my surgeons. There are intricacies, and there would be some amount of decision making in a multi-tumor board meeting, but I would prefer to give NSCT who are cisplatin eligible for everybody.
So let us have some more discussion with the other panelists as well. Dr. Sandeep, what is your approach?
So, sir, same thing. If patient have muscle invasion, then I would like to see the patient condition. Like if patient can tolerate neoadjuvant chemotherapy and the fit and performance status is good, then we can prefer to give neoadjuvant chemotherapy. As we know, this is the standard of treatment. If we can go and have a survival advantage.
Dr. Indranil, how well the concept of neoadjuvant chemotherapy has gone down with your uro-oncologists?
Yeah, it has improved quite a lot over the last few years. Nowadays, most renowned neurosurgeons and definitely the uro-oncosurgeons, they are tending for neoadjuvant chemotherapy.
So Dr. Bakshi is the renowned uro-oncosurgeon in our part of country, and he is a believer of neoadjuvant chemotherapy. Dr. Bakshi, will you ever not suggest any patient neoadjuvant chemotherapy, and if so, why?
So all level 1 evidence suggests that all T2 and beyond all patients should receive neoadjuvant chemotherapy. I would not give neoadjuvant chemotherapy under 2 circumstances. One, cisplatin ineligible patients with renal compromise, I would not probably advise. Second, regardless of T2 or T3, if a patient has significant hematuria with clot retention, his hemoglobin is 5, then I would not wait for neoadjuvant chemo because he needs urgent surgery. So apart from these two, and I used to, for pure T2 tumors, as you very well described, there has been some literature saying that a subset of across all patients, NSCT has a benefit from T2 onwards, T2, T3, T4, and plus. But for pure T2 N0 patients, the benefit is not that great. So I might, I would still advise neoadjuvant chemo, but if the patient wants or does not want, I would still go ahead and do surgery. But apart from these two major indications, one is cisplatin ineligibility and second is ongoing hematuria, I would give in all patients.
Chirag,
So, Manish,
there is
most of
also a possibility of chemoradiation in this kind of patients.
Sorry?
Patients who are not willing for surgery, they can be also offered chemoradiation.
In that case, you will go for upfront chemoradiation or chemoradiation after neoadjuvant chemotherapy?
No, you can go for chemoradiation straight. Means there is a protocol which will say that
But you will say that is not the state of art. Right?
No, but
you will say that it's not state of art.
Patient not willing for a surgery anyway, then you can consider chemoradiation for a localized tumor.
Okay. So in your practice, what proportion of the patient go in that category?
5% or maybe so.
So occasional patient, right?
Means we do take their consent and we do talk to them that this is not the care, but if they are not willing for a surgery, or person is 65 plus and is not willing to lose his bladder, doesn't want that bag on his abdomen, then there are times where you have to take that consent and go ahead. We are right now doing one patient.
Okay. So that should be an occasional patient, not a routine case. But Manish, to you only again, most of the data of the benefit of neoadjuvant chemotherapy comes from the patients who are node negative. If the patient has 3-4 centimeter multiple nodes in the pelvis, in the region only, will you still offer neoadjuvant chemotherapy or you will not?
No. Then you just go ahead with chemotherapy followed by immunotherapy.
Oh. Regional lymph node. Rakesh, what is your opinion?
Sir,
Rakesh?
so I didn't get the question, please.
If there are regional lymph nodes, pelvic lymph nodes of 3-4 centimeters, will you treat them curatively with neoadjuvant chemotherapy or you will not?
As I said, sir, I would probably treat it with neoadjuvant chemotherapy. If it is muscle invasive bladder cancer with a cisplatin eligible patient, I wouldn't lose the chance of giving systemic treatment.
Dr. Sandeep, potentially curable or incurable? Dr. Sandeep?
Yes, sir. Yes, sir. Sir, still we have a hope for cure, and if surgeon is comfortable and one or two single nodes are there, then we can plan for neoadjuvant chemotherapy followed by, or either we have to sample the nodes. First of all, we will sample the nodes. If it is positive one or two nodes, then we can plan and we can have a hope for even cure. And we will discuss with urologist also.
Dr. Bakshi, local regional lymph node, what is your take on that?
So bulky lymph nodes are obviously bad prognostic disease, but what I would do is gives 4 cycles, ask the medical oncologist to give 4 cycles of chemotherapy and assess with a PET scan. If there is a good response or a CR, I would go ahead and do surgery with this. CR in terms of nodes as well as bladder.
Dr. Indranil, what chemotherapy is your preferred choice of chemotherapy?
Actually, for neoadjuvant, we practice only one chemotherapy, that is gemcitabine with cisplatin. So, because for cisplatin ineligible, in neoadjuvant with carboplatin, etc., is not a good option and should not be practiced. So, other options,
a lot of data.
Dose dense MVAC. But we don't practice that, and I believe that gemcitabine cisplatin gives equally good outcome, and we are very much comfortable with the toxicity management. So it suits the patient and the doctor as well.
Right. Manish, if you missed to give neoadjuvant chemotherapy, and if the patient is found to have muscle invasive bladder cancer or maybe lymph nodes are positive, so will you give adjuvant chemotherapy?
Yeah, I would prefer to give them adjuvant chemotherapy. And there are times where the tumor is thought to be operable, early tumor, and then you come up with a node positive disease or a bulky disease which was not expected. In that kind of situation, we do have to give them adjuvant chemotherapy. We generally give them 4 cycles of GemCis. That's our standard protocol. But if patient is ineligible for cisplatin for whatever reason, then even gem carbo is a choice what we are doing.
Okay. Okay. Good. Good. So, Dr. Rakesh, will you perform any biomarker testing at this point in time?
There is some evidence of showing that PD-L1 positive patients who had received neoadjuvant treatment can subsequently get a better benefit with immunotherapy. But if the patient has already undergone a surgery, I think only adjuvant chemotherapy 4 cycles will be the standard of care. There is no role of biomarkers in upfront surgery.
Absolutely. Absolutely. So, a lot of trials are ongoing where neoadjuvant immunotherapy is being given either alone or with chemotherapy. But I hope that we will be discussing about those trials in 1 or 2 years from now. We don't have concrete data right now. Is that right, Dr. Rakesh? Yeah.
Yes, sir.
So,
Absolutely.
yeah, please go ahead. Yeah. So, Hemang, Dr. Hemang, how you will follow up this patient after surgery and chemotherapy?
So annually, it would be 3 monthly ultrasound, CT scan, and imaging for the upper tracts, because these patients, there is a 8% chance that they would relapse in the upper tract, especially those who are smokers. So
Yeah, that's important.
Yeah, ultrasound, urine cytology, and CT scan annually.
So the organizers, I will be going slow. I don't want to cover everything, but whatever I'm discussing, I want to take to the depth. So if the time is up, that's okay. If we cannot complete kidney as well as prostate cancer, we will be spending some more time on the urothelial cancer. So Sandeep, now the patient has metastasis with pelvic nodes, liver metastasis, and bone metastasis. So any molecular studies now?
So, sir, yeah, very, sir, if patient is cisplatin eligible or ineligible and patient can afford the treatment, then we should go for PD-L1, and in cisplatin eligible, and if PD-L1 is high, then we can offer the immunotherapy in this patient upfrontly. And if patient is ineligible, then regardless of PD-L1, we can start avelumab, or at ipilimumab, we can add immunotherapy in these patients.
So, Dr. Indranil, what do you mean by cisplatinum ineligibility and any platinum ineligibility?
Yeah, so cisplatin eligibility, we follow the standard guidelines like creatinine clearance should be more than 50 and no hearing deficit grade 2 or more, and in NYHA grade 2 or more cardiac status. So if no neuropathy grade 2 or more, if these things are not there, then the patient is cisplatin eligible. And if some of these are present, then the patient is cisplatin ineligible. But sometimes a patient may be ineligible for any combination chemo. I would not say any platinum, but not for any combination chemo. The patient cannot tolerate gemcitabine carboplatin because of various other comorbidities, not necessarily only renal or neural. So like poor performance status or multiple comorbidities. So there we consider them chemo ineligible.
Right. So Manish, I think Rakesh or Sandeep said that he will do PD-L1. So by which antibody you will perform if the patient is cisplatin ineligible, but having reasonable performance status? Will you do PD-L1 or you will go for carboplatin gemcitabine?
You can consider. If you are considering atezolizumab, then you will have to do Ventana. If you are considering for Keytruda, there is no need. So you can do and you can also do in molecular markers FGFR2 and 3. So there are drugs available now, not in India, but there are drugs available for this particular molecular status also. So you can consider that also in patients who are otherwise affording and who can reach out to these drugs.
So Manish, in your practice, what proportion of the patient go for maintenance avelumab after cisgem or whatever?
Till date, I have not had any patient who is gone on avelumab. Definitely, we had suggested it to one of the patients, but the patient could not afford the treatment. It's quite expensive as of now. But we do have patients who are following up on other immunotherapies and they're doing well. For bladder cancer, I didn't have a chance. We have some patients who are receiving in metastatic setting immunotherapy. but not in maintenance avelumab. Means loco-regional disease, gem-site cisplatin treated, then avelumab. So we have not had any patients of that.
Yeah. Incidentally, I was involved in this clinical trial, Evelyn Bladder 100 trial. And in the next month in the ESCO GU, Asian subset poster is being presented where I am one of the authors. And a manuscript also is being prepared for publication where again I will be an author in this article of maintenance available. So, Dr. Sandeep, any role of combining immunotherapy and chemotherapy?
Sir, we need to conclude in next 2 minutes interest of time.
No problem. Yeah, sure.
Sir, at present, I don't think it's early to say that we can combine these all drugs with the IO, but still the data and trials are going on and having increasing results. But somehow at present, I will not combine with for metastatic at first line site.
Great. Anybody has the opportunity of using one of these drugs, enfortumab or sacituzumab or erdafitinib? Dr. Indranil?
No.
So, Dr. Minish, any opportunity of using this drug?
No, one of my patients did take this sacituzumab in CA breast TNBC, but she took it in Dubai. So patient was not taking treatment here. Patient went to Dubai and took the drug there. So I have not had any opportunity.
Dr. Rakesh?
No, sir, we have no experience of this, any antibody conjugates.
Okay. Have you started looking for FGFR in any of your patients?
We are routinely sending the NGS for all these patients in the second line setting. So otherwise, in the first line setting, we are not making any major changes for platinum eligible patients. I think we are counseling
And
for
any idea?
switch maintenance, and we are.
Any idea
Which
what
ones?
proportion of your patients are FGFR positive?
We have yet to see a positive patient, sir.
I had one patient in gallbladder malignancy who was positive for this,
Great.
but not for
Great.
urinary bladder.
So I think the next will be RCC and prostate cancer, but we had spent all the time in discussing about bladder cancer only. So I don't think we will go for prostate or RCC in this discussion. And thank you all the panelists for doing an excellent discussion, discussing about practical day-to-day problems in our life in treating bladder cancer. And I hope more and more opportunities where we can discuss a few other cancers in a multi-modality setting. I'm thankful to Dr. Bakshi as well as the organizers to allow me this discussion. So thank you very much once again.